Next, Dr. REVATHY. She's a consultant at Comtrust Eye Hospital, Talcheri, and she'll be talking on OCT.
Good morning. I'll be presenting on OCT, glaucoma spectralis, Heidelberg Engineering, no financial interest. As we all know, glaucoma is a diagnostic puzzle. About 40% of the retinal ganglion cells are lost at the time of early visual field defect. So we need a pre-perimetric tool to diagnose glaucoma before that. The principle of OCT is been already defined. Coming to the retinal ganglion cells, it occupies the inner layer of the retina with the dendrites forming the inner plexiform layer, cell bodies forming the ganglion cell layer, and the axons forming the nerve fiber layer. Together, this constitute the ganglion cell complex. About 50% of the retinal ganglion cells occupy the perifoveal area of the macula. So any modality, with this modality, if there is a decrease in the thickness of the perifoveal area, we can get a clue towards glaucoma. But we know this area will be marred by other pathologies like diabetic macular edema, decreasing in specificity. So the best way is to examine the entire length of RGC by measuring the NRR thickness at the optic nerve head, retinal nerve fiber layer thickness, and macular thickness. The optic nerve head is identified in the OCT as a highly reflective layer, and the termination of Bruch's membrane is known as the Bruch's membrane opening, which represents a stable opening through which all the axons exit the eye. And in OCT, this is regarded as the disc margin. And the perpendicular distance from the termination of the Bruch's membrane to the internal limiting membrane is called the minimum rim width, which gives an accurate measure of neuroretinal rim. So for the analysis, a 24-line high-resolution radial scan is acquired, and it is given as a sector diagram and a flattened diagram, which will be falsely color-coded. And the green line here indicates the database, the black line indicates the patient data, and the gray line may be sometimes present, which will indicate the follow-up scans. The color coding is such that about 5th percentile of the eye above the reference base will be given as green, and borderline when it is 1 to 5 percentile, and outside normal limit when it is less than 1 percentile. The retinal nerve fiber layer analysis is done with a 3.5 circular scan. Similarly, it is represented like a slightly double hum pattern with the TS and TI being the thicker layer. Again, it is the green line is database and the black line is the patient data. And the structural assessment of macula is by a volume scan, which is placed at the posterior pole, which will be aligned to fovea to BMO center axis. And in the macula, we can have various scanning techniques like posterior pole thickness map. Here you can see there is a warmer color which is representing the thicker area, and the cooler color representing the thinner area. And this area, there is we can say it look like a donut. The posterior pole hemisphere asymmetry analysis, where the average retinal thickness of one hemisphere is compared with the corresponding thickness of the opposite. If the squares appears gray in one hemisphere, the retina in the square is thinner than those corresponding to the opposite hemisphere. If it is pitch black in color, that means the thickness variation is around 30 microns. Next, we can individually assess all the layers of the retina, like retinal nerve fiber layer, ganglion cell layer, and inner plexiform layer. And these regions are again color coded according to the database, and the deviation from the database is again color coded. For example, the thickness map will be giving a warmer color for thickness, and in the deviation map, that area will be green in color. The normal retina will be appearing green in color. When there is a variation from the database, that is deviation from the database, it will be given a warmer color. Like here you can see an inferior thinning, and it is given in a red color. This is for the ganglion cell. So coming to the interpretation of an OCT report, first we should see the reliability, assess for artifacts, RNFL and MRW baseline assessment, and macular assessment. There are various errors associated with the scanning technique, and we should keep in mind about the green disease. That is, green disease means all the green is not doesn't exclude glaucoma, and all the red doesn't include glaucoma. For example, errors associated with the optic nerve head scan, here you can see they use a 3.5 circle. So in the myelinated nerve fiber layer, there is no segmentation proper, resulting in a thicker retina. When we use the 4.7 circle scan, you can see the retinal thickness is comparable with the database. Next, associated with the PVD, you can see the segmentation is not again proper here. The inner plexiform layer and the internal limiting membrane is not segmented, resulting in a very thicker retina. Even though the disc is and the visual field are showing glaucomatous changes, the OCT appears all green in color. Next, again the same, the poor delineation of the internal plexiform layer resulting in a thinner retina. If you just look at the sector diagram and the Tisnit map alone, you can diagnose this as a borderline thinning. But when you see the IR image, you can see there is no much cupping and the A-scan quality is very poor. So ideally, we should repeat the scan before jumping to diagnosis. A case of where you can see a disc with inferior thinning and the visual field is not so reliable. The OCT is being done and it shows like a borderline in the sector map. But when you see the Tisnit diagram, you can see there is a definite dipping into the outside lumen limit. And when we go for the macular analysis, we can see the donut being eaten up. There is a definite thinning inferiorly, and this changed the management of this patient. Another example is you can in the disc photo there is definitive superior and inferior thinning, but the OCT is showing only green image. This is because the database of the OCT is inadequate to produce a inadequate to trigger an outside normal limits data with this 141 microns or 14 percentile. Another example is when the patient is having a definitive superior field defect and inferior retinal RNFL defect and inferior notching, but OCT is again green in color. This is because of the retina is very thicker here, maybe because of the diabetic macular edema. We can also assess the progression analysis with OCT. Here you can see the global thinning from 50 to global thinning which progress over the years. Also, you can use an OCT posterior pole assessment. You can see the whether this area is thinned out. The thinner deviated area will be shown in red color. Here you can see the donut being eaten up like from here to here. To summarize, the whole report should be evaluated including the raw data. Output data should be consistent with the clinical presentation. Distinguish the major artifacts. Ensure the optic disc, RNFL and macular analysis are consistent with each other. Thank you.